Well, morning, everyone. Delighted that you're here with us on the way forward. I'm Judy Olian. I'm president of Quinnipiac University, alongside Bruce Copen, who's dean of the Quinnipiac Netter School of Medicine. And we have two distinguished guests with us. I won't go through their entire backgrounds, but I'll just mention Bill Weldon, former chair and CEO of Johnson & Johnson, on the boards, several boards, but including CVS, and most recently just stepped down as chairman of the board of trustees of Quinnipiac. Morning, Bill. And David Feinberg, who is head of Google Health at the moment, previously CEO of Geisinger Health System and the UCLA hospitals. So morning, David. They're both joining us from the West Coast. Thank you for being with us. And Bruce and I will alternate asking questions, and for the audience, you have a Q&A button. Please feel free to add your questions to the list there, and we'll incorporate them as we go. So I'll just start with each of you, Bill and David. What drew you into the field of medicine? David, why don't you start?
So as a little boy, I love kids, and I wanted to work with kids. I think I wanted to grow up and be maybe a school teacher, but then I said, I think I'll be a pediatrician. Didn't come from a family of doctors, wasn't sick, but loved kind of hanging out with kids. And then in medical school, discovered child psychiatry, and that was the one area that after a 2 or 3 month rotation, I felt like I knew less than when I started. And then made the decision that being able to help kids with mental illness and change the trajectory in their life just a little bit could have this huge effect. And then ultimately went into child psychiatry and addiction psychiatry, particularly with teens. And it's a lot of fun to be able to get to know families in an intimate way and be able to affect children and adolescents' lives.
And from there, you because you were so good into healthcare administration. I can attest to that, having known you at UCLA. Bill.
Yeah, no, actually I studied at Quinnipiac. I studied the sciences and was on my way to medical school. And I had a individual who was going to put me through medical school, and then I was going to put his daughter through college. And unfortunately, he passed away from cancer my senior year. And I was married for 2 years while I was in school, and due to that, I needed to go get a job, and I went out and had one interview with J&J, started my career there with the intent of going back to school. And actually, it was well presented to me by a good friend who I hired in France, who was one of the top professors and transplant surgeons there. And I said to Guy, I said, why did you join J&J? And he said, Bill, when I'm on the, working on the table, I'm saving a life. When I work at J&J, I'm saving thousands of lives. And I guess my career just went there, and I felt very fortunate to be there, and never went back to school, and just stayed at J&J.
I never left J&J, yeah.
Right.
Bruce.
So Bill, Johnson & Johnson is working on a vaccine with CVS, and you're on the board of CVS. And they have been innovative in helping support rapid COVID testing around the country. What do you see as the trajectory for development of a powerful therapeutic or a vaccine, as well as a rapidly available and low-costing test?
Yeah, it's interesting. We had a CVS board meeting yesterday, and we kind of talked about all of that. I think if I talk about the testing first, I think we're still learning and moving forward with that. I think there's a myriad of tests out there, some more accurate than others, and some will give you a faster readback. I think they're improving them as they go. I think they're about 86% effective now in terms of finding whether you do or don't have the virus, but it seems to be very effective on determining that you don't have the virus. And I think that the tests are coming along quickly. I think the more pressing question is access to it. And I know CVS has set up over 1,000 stores where you get drive-through testing, but you still have to wait a period of time to get it. So I think the testing is coming along rapidly. It's just a matter of access to accurate testing. I think on the therapeutic side and the vaccine side, my feeling is I think there's like 120 companies that are working on vaccines today. And I think most of them are actually rooting for each other because no one company is going to be able to satisfy the international or the global needs for vaccines. The big challenge is going to be, one, getting them approved. I think Moderna is one of the leading companies, but they're using what's termed messenger RNA, which is a way nothing has ever been developed from before. So we still have to wait to see what's going to happen there. I think J&J's vaccine, I think the other one that's really the leader is the one out of Oxford that AstraZeneca is developing in Europe. And then J&J will probably be next. But I don't see a vaccine personally until early next year or the middle of next year, and especially at the volumes that are going to be necessary, because manufacturing is going to be the limiting factor. So I think they're going to go first to healthcare workers and get it out that way. But I think that everybody would like to see vaccines develop rapidly, and I think that the governmental agencies are working with them to try and do it. But you still have a lot of challenges. One of the biggest challenges, I have a friend who's working with one of the top CMOs, the clinical testing groups here in the United States. And there just aren't enough patients right now to be able to go out and test it with enough patients to be able to find both safety and efficacy. So I think that the challenge is going to be, there's the vaccines that are being developed by different ways, and then B, getting enough patients to be able to satisfy the safety and efficacy issues, and then C, the manufacturability of the products to be able to move them forward. So my best guess is we might have something that looks really promising towards the end of this year. I'm not sure, depending upon the regulatory bodies, how quickly we'll get them approved, and they'll probably get a special approval to use. But I think it'll be into the beginning to the middle of next year before we actually have that. On the therapeutic side, it's a whole nother issue. I think that unfortunately, we're learning more about the virus every day and the response to it. But I think the Gilead product seems to be effective in shortening the duration of the problem for patients. There's now the steroid that's out that's looking to be effective. I'm working at Johns Hopkins on another one that's going to be a therapeutic treatment. So I think we will have some treatments for patients, and hopefully we can, as always, get them on the products earlier rather than later to be able to move them forward. But I think we'll have a therapeutic. We have a couple therapeutic agents right now. I think the vaccines will be towards the end of this year, more prominently for use for the normal public towards the early to middle of next year. And I'm sorry that was a long-winded answer, but that kind of covers what I think is going on out there.
Thank you.
David, do you have anything to add from Google's perspective on vaccine or therapeutic development?
Well, I would just echo what Bill was saying. It's going to take a lot of really thoughtful clinical trials. We have, through our Verily sister company, a project called Baseline, where all the folks that are getting testing are enrolling in the trial. I think from a US standpoint, it probably would be helpful to think of some other parts of the country other parts of the world where the virus is just getting to, because you have a better opportunity to then enroll people. Unfortunately, we may be creating that same situation here where we see our cases going up, and it's a terrible thing to say, we may have enough people to start doing our trials here. So the patient enrollment is going to be difficult. And then from a Google standpoint, we're really, really focused on authoritative information. And so we want to make sure that misinformation, which we battle on anti-vaccine, doesn't get hold here, so that people get the right information, can make the right decision with their healthcare provider about whether a vaccine is appropriate for them or their family or their loved ones.
So part of the race to not just develop the vaccine, but actually logistically supply the vaccine to the billions of people on the planet, almost seems to be a race of competition across countries. We're seeing the European Union engage in contracts up front with some companies like J&J, I think like AstraZeneca, where they're saying if a drug is developed, we're giving you hundreds of millions of dollars contracts in advance. Same here in the United States, Sanofi, some startups. So is there going to be a coordinated effort, or is it a race to the finish line where countries compete with each other?
I'll defer to Bill on that.
Go ahead, please.
No, please.
Well, it's not really a race to the finish, Judy, because as I said, I think that everybody wants to get there as quickly as possible. But as I said, I think everybody's rooting for each other because there's a great need, and the need will far exceed what any one company can supply. I do think, the governments, the U.S. has given literally billions of dollars. They gave almost $500 million to J&J to build manufacturing facilities. And J&J is committed to doing that, but it's long before the drug has been proven to be safe and effective. So many of the companies, I know AstraZeneca is, J&J is, and others are actually investing heavily in manufacturing facilities before the drug is even proven to be safe and effective. So that when it does come, they'll be able to, to deliver on the promise. But I think they're way ahead of it right now. And actually the governments have given lots of money out prior to approval of a product to make sure when it does come that it will be, that they'll be able to supply. I'm sorry, David.
No, I agree.
So let me just flash on the screen just a quick snapshot that I'm sure many of you have seen. This is just one way, and this is a snapshot from last week, I think, of the very different patterns between the US and, let's say, Europe. Some of the countries that have, like France and Italy and Spain, that had major outbreaks. The trajectory is very different between the two continents. What do you think are the main reasons that explain that? Maybe start with David and then Bill.
Sure. Well, a couple of things is Italy got it earlier, so that they really were overwhelmed and locked down before us. So the time sequencing here is important, but you kind of see that in the graph. The other thing is that in the US, I think you see very, very different pictures based on particular regions. And that spike is likely because of increased cases in a few states. We're a big country from a geographic standpoint, but probably in the same space as Germany, France, Italy, and Spain. We with Apple, created a tool that allows contact tracing. We call it exposure notification. And I can't remember the 11 countries that have done it, but I do think it is Germany, Italy, I think France. And so what that does is when, let's pretend that I was exposed or I'm positive. Well, I could come home and tell my family, and maybe I could tell other people that I knew that I was in contact with. But if I was on a bus, it's very hard for me to tell the other people on the bus, particularly the ones that sat next to me, that they've now been exposed. So in a very privacy-first way, we used the technology to allow the phones in a blue.
Oops.
David, I lost you.
David, we've lost you. Why don't you kick in here, Bill, until David comes back?
Positive. So we've seen that being taken up in other countries. In the US now, some states are starting to get interested in that. I think that's a very, very small piece of the puzzle, but is part, I think, of the explanation in a total toolbox to make sure people understand social distancing, that people understand how well communities are avoiding close contact, mask wearing, etc.
So we lost you for a moment, but I think you talked about the criticality of tracing.
Yes.
Yeah. Bill, what's your take on this? And I think we can unshare. Thanks.
Yeah, I'm not sure I have much to add to what David had to say. I think you're right. There are hot spots. I also have to say I'm very skeptical about any of the data we're getting. I think the media, I'm not a fan of what the media is representing, but more importantly, in the tracing, because of the inability to test a lot of areas and whatnot, I think we're still learning a lot about the virus, and I think there's probably a lot of people that are asymptomatic that we don't even know about country by country. But I think what David said is really, the key issues.
And let me remind people to put their questions on the Q&A box. Thank you. I'll ask David now. Google has these incredibly powerful digital platforms, tracing and clustering capabilities. You get, I think, over 1 billion health questions a day at Google. How has your digital capability and information access, how is it helping us address this global health crisis? What are some of the levers you're able to use to exploit that digital platform and information access?
Well, thanks, Judy. When this broke, for the first time ever, Google created an SOS page that had something to do with a medical condition. We've done them previously for natural disasters, but this was the first time we did a medical SOS page. And what that means is if you typed in google.com/COVID or anything around coronavirus, you got to a page that was completely curated by authoritative information, local public health, national, WHO, CDC. There were no ads. And we tried to make it very, very easy for people to get that authoritative information. So that's the first time that Google's done that for a medical problem, and proud of my team for working on that. What we started to see—
Can I ask how many hits a day you get on that?
We get a lot. We get a lot. What we saw on those hits, well, if you actually want to take a look at the hits, you can go to Google, trends.google.com, and you can see relatively. So you could put in Super Bowl or Beyonce or whatever you want, and then put in a term like COVID, and you could see the difference between those types of things. And you really get the magnitude of what people were looking for. What we saw over time was it went from information about the disorder to a lot of mental health issues. We saw a lot of searches for anxiety and depression. So we launched, it's now probably been about a month and a half ago, an anxiety screener online. So if you were to Google in anxiety or anxiety disorder, you could take a self-assessment of where you are on a spectrum of anxiety disorders. And previously I'd done that for depression and post-traumatic stress disorder. And what we saw, and the data would tell us, that those suffering from depression and anxiety, diseases of despair like suicide, substance abuse, alcoholism really increase in times like this, when the economy gets bad, when the social isolation leads to when social distancing leads to social isolation, when you're stressed because of work and food and toilet paper and being at home and not being with loved ones. On average, and this is before COVID, people would spend 7 years before they would share a mental health disorder with a loved one or a family. So we felt like if we could get people to screen themselves and then through virtual care tee up treatment, we could really close that gap. So to me, that's an example of how we use the platform to see what was going on and really to help our users, in this case, get treatment. And we're talking about, a third of Americans talking about suffering from depression or anxiety during this time. So that's an example of what we did. We also had a COVID screener that we put up in partnership with the White House and the CDC, and had done similar things around the world. We also did a community mobility reports. So this is in the US, it's on a county level, but every county, and this was because public health was asking us this. Counties could then look and see, are people staying home? Are people going to the park? Are people going to the supermarket? And use that information to make policies. And we see daily that people are actually around the world in multiple countries using our ability to aggregate in an anonymized way people's searches or movements, etc. So those are things that I think I'm really proud that we were able to do to help people kind of get through what's really been an amazingly difficult time for the world.
You know, I'm going to pick up on what you just said and weave in a question from a member of the audience, Rahul, who's suggesting or asking, do you see a shift from provider-based healthcare providers to platform-based providers? And of course, one key example is telemedicine. And you alluded to that, David.
Yeah, so I don't think telemedicine moved on the curve with this. I think it moved to a whole different curve. So we saw uptake on telemedicine and virtual care, just phenomenal numbers. So what we tried to do through maps and other tools that we have is to make it really easy for people to access that care. So if you were now to Google even sore throat or sprained ankle or do I have COVID, we bring up virtual care options, both with your local provider and some of the big national providers, so that people can easily kind of access this care, along with instructions like don't go without calling in advance if that's what the urgent care wanted, because they may be using a different waiting room for the COVID patients. So really make it easy as people try to get information for healthcare. And then we want to make it easy for them to get into action to that next step. And that next step often is a visit. And it was very clear that a lot of people were asking for these virtual visits or telehealth. And we added those types of features and also made it easy for a lot of the smaller practices around the country to use our products to create HIPAA or privacy secure ways to set up telemedicine for their offices.
Judy, can I jump in for a second? Because we reviewed that with CVS yesterday. And so far in the first 6 months of this year, we've had 20 times the amount of use of telemedicine through the mini clinics and other areas than we had all of last year. And it's just absolutely exploding. And the technology that allows you, as David was saying, the technology not only to talk about your symptoms, but actually to be able to work within a clinic to work with doctors to be able to look for otitis media, for example, to look into your ear, to look into your throat. There's a lot of work coming out of Israel right now where they've done tremendous amount of work with distant doctors actually using telemedicine to be able to diagnose and treat patients. And, you know, I think one of the things you were going to talk about later on, but I think is really going to change in medicine is going to be the ability to really get treatment of many symptoms, diagnostics, treatments, and also deliveries from pharmacies where the patient may never even have to leave the house to be able to get diagnosed, treated, and get their medications to be able to treat themselves. So I think that there's going to be a huge change in the future of medicine in the way it's handled.
Bruce.
So I guess I'll ask this to David. One of the things that we've learned from the COVID pandemic is that it's revealed large disparities that exist in minorities' access to healthcare in our country. How can companies like Google and J&J offer greater access to products, data, or technology to help close those gaps? I'll start with you, David.
Yeah, thanks, Bruce. So as somebody who's...
David, if I can interrupt, what you both just talked about could actually exacerbate the divide in access to healthcare if there is a digital divide due to poverty. Sorry.
Thanks. So I think it's a really, really important issue. And for those of us who spent our career in healthcare, this isn't new. The health inequities among people of color and low socioeconomic are such that you can live a few miles apart. You could go to the same doctors in the same hospitals in your city as your neighbor that lives a couple miles apart and have life expectancy differences of 20 to 25 years. And that's driven by not bad doctoring and bad hospitals and bad nurses or good healthcare. It's driven by the other stuff: access to food, safe neighborhoods, transportation, chronic stress, really the diseases of despair that definitely affect those communities at a higher rate. It's racism is a healthcare issue. We need to do a lot in that area. And I think we've been very careful to make sure that as we develop tools around artificial intelligence, that we're not biased in those data sets. So we're really explicit about, are we getting the right people? And we have potentially a dermatology product. Have we used it on different skin colors? As we've looked at, to your point, Judy, about access to care, we want to make, Google's mission is to make information universally accessible and useful to everyone. And we say everyone, that's really code word for everyone, everybody. So we really check as our tools come out, do they decrease this equity in healthcare that's particularly affects the poor, needy, and oftentimes is racist. So examples could be, we have tools that can improve mammography. We have a tool that can look in the backs of people's eyes and diagnose diabetic retinopathy actually as well, and in some cases better than an eye specialist. We've now launched that tool in India and Thailand, where there aren't ophthalmologists at the same percentage that you would see here in the US. So people are getting screened that likely would have never been screened and had gone blind. So we're very, very focused on building our tools and making sure that we combat the racial inequities that are built into healthcare. That being said, we have so much more work to continue to do. We have a good partnership with Morehouse College and continue to look at the effects. In COVID, we've seen in some cases 2 to 3 times increased death rate among Black Americans and others of color. So we have our work cut out, but that's not new in healthcare. This problem has existed pre-COVID. Maybe the silver lining here is it's been brought to light and the world or our country is now attending to it so that we can really think about every policy that we do and how we can combat the racism that's already built into healthcare.
Bill?
Judy, my wife and myself, Barbara and I have been very involved in the whole healthcare area in the underprivileged areas in Florida, for example, and we're setting up clinics and working with them. And to echo what David said, there's a lot of issues there. One of the things, if you take it beyond just a diagnosis, and J&J was very involved in, as you said, in diabetes, hypertension, obesity, and the comorbidities associated with those from especially the Black, Hispanic, and Native American population, where the incidents are much higher. Part of the problem is you can have all the diagnostics in the world, but if the patients don't go and follow up on treatment, that's where the problem is. So access to healthcare, even if it's not, the affordability is one issue, but even if you make it affordable, patients, and you talked about transportation, David, transportation is a big issue. We're finding that you need vans to go around or you need to set clinics up in certain areas. But you can get to the diagnosis, and J&J was very involved with the Black community looking at, diabetes, hypertension, and these things. But once the patient was diagnosed, they didn't follow up with the physician, or even if they did follow up and get a prescription, they didn't get the prescriptions filled. So I think we have to look at the diagnostic side of it, but then we have to find ways to make sure that people are getting into the treatment phase and following through with the treatment that's needed. The other side of some of the, there's so many social issues associated with so much of this that, many of these people are day workers and they have to go to work to get paid, so they're not going to go worry about coronavirus or a lot of other things like that. So, it's multifactorial, the issues that we're dealing with, but with Google and with J&J and with other people that are really involved, I think that we can start to bend the curve a little bit here, but it's going to take a huge effort and a huge educational process. It's going to really be able to address the whole racism, if you want to call it that, in healthcare.
I'll just follow up, and I think you were alluding to just the ability to afford all the access to prescriptions, to transportation, to be able to take off work. So there's a poverty issue that's driving the inability to comply. There's a question here about contract tracing and public compliance. We have seen data that show that even when you get calls in Florida, or we have seen it in Connecticut, people are not forthcoming in providing data around tracing. To what extent is that an impediment to the containment of COVID? And is there a shame factor or an embarrassment factor in admitting that one has COVID? How do we overcome that? And this is really coming from one of our audience members.
David, you may be better from Google's perspective to answer that.
Sure. I think it's about trust, and I think it's about understanding. I mean, it's pretty amazing that America knows things like now bend the curve and social distancing, right? These public health things. I think public health in America has been historically underfunded, and yet you see how important it is. I was reading a paper, I think it was from about 100 years ago exactly, about the Spanish flu pandemic, and the advice in there was the same advice we're giving now, and it's almost like we haven't learned. So we are in this world together. Coronavirus does not know the boundaries of politics or of geography, and we need to, as a world, or in this case, as our country, really understand that me wearing a mask, particularly if I think I'm sick or if I'm an asymptomatic carrier, doesn't help me, but certainly helps my neighbors. So I just think those types of messages are really important, that America understands we're in this one together. And if we don't get this right, it has so many consequences beyond the medical sequelae of people dying, the morbidities associated with it, the mental health issues, there's all the economic issues. And so these two go together. And I think it's really around people understanding public health. And I think we've made a big step forward, unfortunately, with this event, where people now start to understand why this is important.
I don't think people understand yet the long-term effects that are going to come. I think we're just starting to realize that the virus isn't really that well defined yet, and that there are many, let's say, longer-term effects that they're worried about that could be popping up with these people that have been exposed to it. So I think that's going to be a big issue.
Bruce, you want to continue?
Yeah. Artificial intelligence can be very powerful. And I was wondering if you could describe the ways that AI is transforming medicine and healthcare. Both of you are involved in various transformational initiatives that are doing just that. So, Bill, you want to take that one first?
Sure. I think AI, machine learning, artificial intelligence, whatever term you want to put on it, is going to be critical to the future. And I think with the technology that Google and others have, it allows the ability to get deeper and deeper into the diagnostic phase and the treatment and the outcomes phase to look at things that heretofore may not have been able to be visualized. So for example, the company HeartFlow that I work with, the more information we get about cardiovascular disease, the more we feed, I call it feed the beast, which is the computer that's analyzing this. And you get technology that's able to get to things that we had never been able to get to before, to understand, what is going to be if you look at it, the symptomatology that you have, and then the treatment that's going to be most effective, and also to be able to predict patients that are going to need certain technologies or treatments and improve outcomes dramatically. So I think that AI is going to continue to advance medicine in ways that it's never been advanced before. And you can take that down to, and Bruce, you're more familiar with this than I am, but when I was at J&J, the advances that were being made in the identification of molecules, peptides, proteins, they're able to treat diseases and be able to factor out tons and tons of them. And we had a group that actually George and Barbara Bush put together to look at the treatment of cancer patients and be able to really factor out what are kind of dry holes. Let's not go down this area. Let's go over to these areas and look at them. And I think that the diagnostics are going to play such an important role, and you take that and combine it with the technology that's going to be able to develop treatments for these diseases. I think that AI is just going to explode the treatment of, various diseases that have never been treated before. The other one that I think is so prevalent is the whole metabolic disease area, where we now have, you talk about wearables, you talk about all of these things. We're looking at, somebody had me review something the other day where they actually had a implant they could put in their tooth that through saliva could manage the, look at the A1C and the things for treatment of diabetes, and be able to measure what was going on and to help facilitate the physician who would get a feedback from this to be able to work with the patients on treating diabetes. So I think that, we're only limited by our imagination. And I think that's the critical thing, is if we can get into this and really follow through with it, we'll be able to treat, so many different diseases. And I think, it's just, we're unlimited the potential that it has.
Hey, Bruce, let me give an example that adds to what Bill said, because I completely agree. So we have a team in London that works with the hospitals there, and we developed an app that allows the rapid response team in that hospital, the nurses and docs, to get notified. Their job is, if a patient's in the hospital and is getting sick, to go see that patient. And so what we picked was this measure of kidney function called creatinine. And if the patient's creatinine went up, this rapid response team on a mobile platform got notified and got to go see the patient. Just creatinine. And the time from diagnosis went from 4 hours to 14 minutes. There was a 17% reduction in the cost of care, and 30% less patients had cardiac arrest. So it was a win. And then what we did was say, instead of looking just at creatinine, let's look at 600,000 variables per patient. And we did this in a partnership with the VA, and we looked at 70,000 patients and said to the computer, instead of just looking at creatinine, look at everything in real time on these patients and tell us when you think somebody is going to go into acute kidney injury. The same thing as that creatinine going up. It went from 4 hours to 14 minutes with creatinine. With artificial intelligence and our machine learning, it went to -2 days. So 48 hours before a patient had any clinical deterioration, anything that I would notice as a doctor. There was no bump in creatinine. There was nothing that we would know to respond to. The computer was able to predict with 90% accuracy who would go on to dialysis. So you imagine that you're going to be told now as a doctor, this person potentially in your waiting room that looks really healthy and fine is going to be deathly ill in 48 hours. We don't even know what to do with that information, right? We, I think, have come upon anticipatory medicine, where the computers are going to warn us that something's going to happen that's bad with unbelievable accuracy. So we need to work with health systems and doctors to now figure out, what would you do? Well, maybe you would stop some medicines that potentially have toxicity. You might want to give fluids, but we don't even know what to do when you get that information. We have a team working on computer vision and have shown that we can have less false positives and false negatives on mammography compared to radiologists. Well, that's great, because there's a lot of women who are told you need a lump out when they really don't. And there's a lot of women who are told your mammography's fine, and it's not. But as we put these tools in, the other thing that we've learned is we've got to build them in the workflow, and we've got to include the healthcare provider, because they then need to go have a discussion with the patient. So we see this as a tool that can really increase and make clinicians superheroes. And when you think about that, these kinds of tools, a derm tool that can diagnose dermatologic disorders at the same level as a dermatologist, is very helpful in rural America, where they only have a nurse practitioner, right? We've now up-leveled that person to act like a specialist. So I just want to echo what Bill has been saying on this one. I'm positive that this technology can save lives. The key, I think the two keys are, we got to build it in the workflow, and people have to trust us. If we lose the trust, I think this technology stays on the shelf and we really missed our opportunity. So we have to be clear about what we're doing, how it works. Are we making sure we're testing it on the right population so that we're not disadvantaging certain people. And hey, if it's my wife or daughter, as far as that mammography study, there were things the computer missed and there were the things the doc missed. What I actually want are both. I want that doctor using these tools when they're caring for my family.
You know, and if I can just add one thing to that, because I couldn't agree more with what was just said. The critical thing here also is to align the incentives for the physician. Because today in the United States, you know, some of the technology is actually, you know, and I think you talked about radiologists a minute ago. Some of the radiologists are losing their let's call it income because of some of the technology that's superseding that. And we have to find a way to make sure that we are involving everybody that needs to be involved in the treatment, and also that they are compensated accordingly based upon the skill sets that they need to do this, and to help educate as these new technologies come into play. We saw it when we went into minimally invasive surgery, that a lot of surgeons didn't have the dexterity to do it, but there was a huge movement that way. And we really needed to make sure that the compensation was aligned with things, because the physician can get in the way. And that's something that we don't want to have happen as we move forward.
You know, I'm just going to observe a couple of things. I saw a paper a few days ago that talked about anticipatory medicine around COVID, what David had mentioned, being able to predict 2 weeks in advance where the COVID outbreaks are going to happen, using things like anonymous mobility data from smartphones, doctor searches on a physician platform called UpToDate, readings from a smart thermometer that uploads automatically, and it integrated those data streams and could predict where the COVID cases are going to happen 2 weeks before they happen. And in fact, they're predicting an outbreak in New Hampshire and Nevada based on those data. To your point, David, I'll just mention a statistic, because you're so concerned about the trust that consumers have in technology. A survey of consumers said that only 38% believe health tech has the proper security measures to protect sensitive data. So we have to get over that in order to have all of the richness of the uploading of information to machine learning apps, so that we can fully exploit the power of those data. Now, I don't want to run out of time, and we could go on for a long time. Could I just ask a question about interoperability? Because we have all of these providers, we have hospitals, we have doctors, we have pharmacists, we have insurers. Both of you are involved in different parts of this supply chain. And yet, as a consumer, when I go anywhere, I have to repeat my information every time. And it's very hard for the various providers to see me across these data sets. So how do we have a greater interoperability so that every person can be healthier, and also that we can provide lower cost healthcare? Bill, do you want to start with that?
Yeah, I think we need to really get to electronic medical records, and Mike Levitt, when he was head of hospital.
HHS, Health and Human Services.
Yeah, exactly. When Mike was in charge of that, he basically said, he drew the analogy of the railroads years and years ago, when they didn't have a standardized format for how far the rails needed to be apart. And the only way they could get the railroads working was to come with a standardized format that could be able to do that. I think we need to have a standardized format for electronic medical records. And though people are very resistant to this, I think either the government or somebody has to regulate that, so that you can, wherever you go, you have a card. And when I lived in the UK, when I lived in London, we actually were investing with the UK government and carrying kind of a credit card around that basically said, no matter where you are, you can use this credit card in the UK, and it will bring up all your medical records so people will know exactly what was going on. I can tell you, years ago at J&J, we had a product that was out there that actually had some drug interactions. And the product was a huge product, but we found that after looking at many issues, that patients would get a prescription in the Northeast, and in the winters they would go to Florida, and the Florida doctor didn't know what the product didn't really know the history for the patient, and they would put them on another drug that would cause a cardiac event and could actually cause fatality. But they didn't know that the patient was on this longer term product, and then they were put on that one. So I think electronic medical records are going to give you the ability to go any place, anywhere, and know all of the issues that you have and everything that's going to move it forward. So I think that the first step is to get some type of standardized form that, whether you're in Lake Oswego, Oregon, or LA or Connecticut, that you're going to be able to give when you go into an urgent care, a mini clinic or whatnot, give a card to somebody, they can put it on and they can see all the products you're on, all the issues you have and everything else, so that they will be able to treat you appropriately. And I think until we get to that standardized format, we're going to have a lot of problems. We're going to continue to have problems. And I think Google can be a huge leader in this area to be able to help standardize some of this stuff and get us to an electronic medical record. So I think that's going to be a large part of the solution.
Yeah, so it's exactly what we're working on. The electronic health record companies have done an amazing job. They get beat up a lot because they've actually digitized the records. So now they're digital. They don't have great user interface. They're really built, I think, ideally for billing, and they don't communicate well with each other. But and I think the current administration in Washington has done an amazing job pushing interoperability, and has now come out with what those standards need to be. And we're starting to see that uptake. We want to be a player in that, and we think it's really important to make sure that you don't have to have a colonoscopy twice because the doctor can't find the first one. So in our work with Ascension, what we're really doing to start with is, even at one hospital, they're using multiple types of electronic health records. We want to build on top of that a typical Google search bar, so that that doctor can search all of your records, or that nurse, and find it, even if it was faxed in, even if it came from a lab system that's not necessarily connected to one of the big electronic health records systems. But the electronic health records got this digitized. Now it's our job to actually make this useful and be able to make it interoperable, that you can go back and forth. And the other key piece here is we have to have a frame shift in mind. This record belongs to you, Judy. This is your record, but we've always treated it like it belonged to the hospital and the doctor. And once consumers get it, and consumers then have an ability to get value from it. Hey, you shouldn't be put on this medicine because you have this genetic profile. Hey, only 1 in 100,000 times would a doctor ever prescribe this for somebody in a situation like you. Are you comfortable taking it? Those kinds of things that tell you about, with consent, who in your family, you want to be able to say, hey, it's time to remind, your elderly parent or your kid about an immunization. We have to add value to it, because simply collecting the information on your phone isn't going to really drive the type of action.
Sadly, we're getting towards the end of our time here. Maybe Bruce, you want to ask the last question?
Sure. It's a little broad, so but how do you think healthcare delivery will change post-COVID?
I'm sorry, I froze, so I missed the question. I don't know.
So this is our last question. How do you think healthcare delivery is going to change post-COVID? We've touched on
I'll say there's a couple
aspects of that.
I think we kind of talked a little bit about it earlier, and I think telemedicine is going to start playing a bigger and bigger role. And I think technology is going to enable the changes in medicine to be able to move forward. I think all the things we've been talking about, Bruce, to me are the things that will enable it. I think telemedicine is going to be something that's going to be very important. I think the ability to use machine learning and AI to be able to get better diagnostics and yield better treatments. I think all of these things are going to continue to evolve and be able to give, and I look at it as better outcomes. I think that's the critical thing. It's going to be better outcomes. And I think you can see it in robotic surgery. You can see it in all kinds of different things that are actually creating better outcomes and better ways to move the patients forward. So I think it's all the things we've been talking about that are going to contribute to it. And I think as more and more like Google are going to be able to, let's say, amalgamate and bring together data and information and take the data and put it into usable information for physicians and healthcare providers, I think it's going to really, change the whole face of medicine.
Do you think a company like J&J will want to repatriate the supply chain, bring it back closer to the U.S.?
Yeah, Judy, I was on a panel the other day talking about, obviously this has brought a lot of attention to China and India and whatnot. And I think that, my comment at that panel was the really, I'm going to say companies that understand the issues have multiple sources. It's not just one. So, and part of the supply chain people have to help their boards and their let's call it their senior management understand that there may be a cost involved in doing this, but you need to make sure that you're not just dependent for healthcare, especially on one country or one facility or one area. You have to have multiple facilities, and it may not be that you have them registered to be able to do backup manufacturing if necessary, because it's going to take you a long time to get it approved by the FDA or any of the other regulatory bodies. But you need to have backups. You can't just have your total supply dependent upon one facility. And we've seen that in the area of oncology, where there have been products that have been very important, where actually companies have outsourced the manufacturing, and then the companies that are doing the manufacturing have said, we're going to get out of the business, and then the cancer patient can't get access to their product. So it's not just being in China or being in India, it's making sure that you have backup supply sources that you can turn on. You don't have to have them actively involved, but you have to have them registered so you can turn them on if necessary. So I think good companies are going to become less dependent upon one source and actually develop backup supply.
David, question about changes post-COVID in healthcare.
Well, I don't want to repeat what Bill said, so let me add two that I think are important. I think post-COVID, people now understand how important public health is. And I think that that's a real positive. And I think post-COVID, the health inequities and racism in healthcare will get the attention that it deserves. And we have a chance of improving and closing the gap that people get as far as care.
Well, we could go on for a long time. Thank you so very much, David and Bill, for getting up early on the West Coast and joining us and sharing the wide wealth of experience and wisdom that you have in the field. And Bruce, thank you for being our partner here in joining us for the panel. And we look forward to our next Way Forward. And thanks for everyone who sent in questions and joined us. Have a great day. And
Thank you.
Thanks very much. Bye now.